Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, I am Dr. Amasi Kaniaku, an assistant professor at Northwestern University Feinberg School of Medicine. Welcome to our last episode of Clinical Clips from IAS 2025. So first, I want to take us through an abstract that was focused on cabotegravir exposure in pregnancy and neonatal outcomes. So this abstract pulled data from the antiretroviral pregnancy registry. So in terms of cabotegravir exposure, there were 42 pregnancies. Approximately 75% of the cabotegravir exposure was in the setting of HIV treatment. The other 25% was in the setting of HIV prevention. And the majority of cabotegravir exposure was prior to conception rather than cabotegravir being initiated during pregnancy. There were 35 live births, and there was one birth defect that was noted, congenital ptosis. It's a small sample, but currently there's no significant concerns for increased birth defects due to CAB-LA exposure. Next, let's talk about PrEP experiences and challenges in transgender women in the U.S. So their ENCORE cohort is a longitudinal cohort study of transgender women in the United States and Puerto Rico. And of those participants in the cohort study, they looked at a subset that had used PrEP in the 6 months prior to enrollment, which was roughly 18% of their participants. The majority of the reason why participants selected oral PrEP really had to do with familiarity around what was available and provider recommendations. And then when they looked at differences along race and age, they did see that there were differences in the motivations for some Black and Latina transgender women who were participating. It was heartening to see that roughly a quarter of their participants reported no challenges with either form of PrEP. But then challenges that they did see, again, they saw differences according to race and age. And those differences often centered around concerns around stigma, concerns around cost, concerns around acceptability or accessibility. And so taken together, all of this continues to reinforce the need for us to continue to provide patient-centered choices for HIV prevention, particularly as we continue to make efforts to address the HIV disparities that transgender women experience. Now shifting gears, I want to talk about concerns around weight gain in people living with HIV and what is the role that ART may play. So first, in a study that looked at changes in weight in people living with HIV over 3 years, they wanted to understand what were the key predictors of significant weight gain in this population. So they used data from the US-based TRIO HIV Research Network. All of the individuals that they looked at had viral loads less than 200 copies per mil at baseline, as well as at the 3-year follow-up, and none of them were participating in a clinical trial. Overall, in their sample, 12% of the participants gained 10% or more weight and shifted to a higher BMI category. And then when they did their logistic regression analysis, they saw that factors associated with clinically significant weight gain were younger age, having a normal or underweight BMI at baseline, low CD4 count at baseline, identifying as Black or African American, and reporting female gender. There was limited impact related to the antiretroviral regimen, except they did see that TAF exposure in the 12 months before the baseline period was associated with the lower odds of weight gain. Now, a second study of interest in terms of weight gain in people living with HIV is the A5391 study. And so in this study, they evaluated whether or not changing to a doravirine-based regimen would either cause weight loss or stabilization in people with HIV who were obese and currently on an integrase with TAF-based regimen. So 145 participants in the US were randomized to either doravirine plus FTAF, doravirine plus FTDF, or to continue their current INSTI-based regimen. All three arms lost weight, but there was no significant difference associated with switching regimens overall or when they did subgroup analyses by race and gender. So overall, this question about what's the role ART plays in terms of weight gain, it seems that that this emphasis is overall doesn't support that we should be trying to switch people's regimens based on this and really shifting our focus to look at other interventions to help people lose weight. And now I want to conclude by going through some rapid fire posters, late breaking posters. So first is a poster that evaluated cases of virologic failure in long-acting cabotegravir and rilpivirine, who were then put on BIC FTAF for treatment. So in this case series, 6 individuals experienced confirmed virologic failure while with resistance while on rilpivirine, and so they were placed on BIC FTAF once daily. All 6 had dual class resistance, and then there was virologic data available for 5 of the individuals. And of those 5 individuals, all of them achieved virologic suppression on BIC FTAF. More studies will be necessary to evaluate whether or not this strategy is something that's possible in the setting of treatment failure with resistance to rilpivirine LA. Now I want to take us to look at liraglutide for obesity and HIV in South Africa. So GLP-1 receptor agonists have not been rolled out in people living with HIV that are obese in Africa. And so this study was a single-arm study to assess the acceptability and efficacy in South Africa. 40 people living with HIV participated. They deemed liraglutide to be highly acceptable, and it was associated with a statistically significant decrease in weight, BMI, weight circumference, hemoglobin A1C, depressive symptoms, and it also reduced indicators of poor sleep quality. Now I want to talk about the results from the Sangura study that looked at the efficacy and safety of switching from BIC FTAF to 2-drug dolutegravir lamivudine in older individuals living with HIV. This is a single-arm study that was conducted in Kenya, so 60 years or older, living with HIV with suppressed HIV viral loads. At 24 weeks, which was the primary endpoint, all participants had HIV viral loads less than 50 copies per mil. And now for the last poster, this poster presents the qualitative sub-study results of the CARES clinical trial. And so the CARES, as a reminder, is the study of long-acting cabotegravir rilpivirine in people living with HIV with suboptimal HIV control. So 133 participants, roughly equal from the injectable and oral arms, participated in in-depth interviews, and then an additional 39 participants participated in 4 focus groups. The key themes were that participants reported treatment fatigue and HIV stigma related to oral treatment. Participants in the injectable arm expressed positive attitudes overall about long-acting treatment and a desire to remain on this formulation. Participants in the oral arm, about 3/4, were also interested in switching to the injectable formulation to reduce pill burden, increase privacy, and treatment convenience. So, long-acting injectable ART provides an additional and welcome choice to patients as a way to tailor their HIV treatment. In closing, thank you for joining us for episode 4. Please refer to the landing page for slides and to claim your continuing education credit, as well as view our previous clips from the conference.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.